invited to come speak to you. I'd like to give you guys a shout out, both as a group and individually, as perfusionists, for supporting and playing an important role in ECMO throughout all these years. So we really appreciate that. I have no relevant disclosures, but what I want to do, I want to introduce my topic by describing what I would call the VV ECMO paradox. We place patients on VV ECMO because they're hypoxic and have difficulty with being oxygenated. Yet, most of our patients, at least early on, after they get put on VV ECMO, are still hypoxic. So why is that? Does that mean the patient is any worse off, or at least no better? And this is, I suppose, absence of lung function. This is probably why. In our current management of patients, we now go to extremely protective lung strategies on mechanical ventilation. And in doing so, in reducing the pressure and volume that we deliver to these lungs, we end up with lungs that look like this in many of our patients. In fact, I would submit that most of our patients go through a phase in which their X-ray looks just like this. There is no air in this chest. There is no lung function. These patients are entirely dependent upon the extracorporeal circuit for maintenance of gas exchange and sustaining their life. I'd like to introduce this topic by making a distinction between the terms hypoxia and hypoxemia, because they're sometimes used interchangeably, but they actually have very specific meanings, and I will base my talk on these meanings as well. Hypoxia is a condition in which there is inadequate oxygen that's available to the tissues. So the tissues at the cellular level are getting an inadequate amount of oxygen to perform normal cellular function. It can occur because of extreme hypoxemia, can occur because of anemia or low blood flow, which we refer to usually as ischemia. Hypoxemia is merely the presence of low oxygen levels in the blood. It does not imply that the tissues have inadequate oxygen available for their consumption, although it's very possible that they might. And a fundamental concept of VV ECMO is that hypoxemia may exist, but may still allow adequate oxygen delivery to tissues and avoid hypoxia. Hypoxia really must be avoided in our patients on ECMO. Hypoxemia, I think, should be avoided, but often we'll have to accept its presence. I'm going to introduce this concept, and I think Dr. Bartlett is going to reiterate this in his talk. We have to shift from looking at saturations in PO2s to looking at the oxygen content of blood and how that is delivered to tissues. The concept of oxygen delivery, something that's basic to physiology, but we seem to have lost sight of as we move from the classroom into the clinical arena. But this concept is very important, and we'll be coming back to it. If oxygen delivery is adequate, the tissues are happy, they receive plenty of oxygen. If oxygen delivery is inadequate, then several things can happen. Metabolically active cells can become inactive. We see this in the myocardium. We call it myocardial stunning. The cells adapt to the inadequate energy available to them and shut down their function. Other cells that must continue to perform actually end up switching from aerobic to anaerobic metabolism. One of the fundamental concepts is that we have to maintain both an adequate oxygen content and sufficient blood flow to get oxygen out to tissues. As oxygen delivery drops, the tissues extract more and more to try to maintain and take out of the blood what they need. But there's a limit to that. Once we get to a saturation of around 50%, below that level, we tend to see cellular dysfunction. So one of the things I'm going to focus on in oxygen delivery is that even though we can tolerate hypoxemia, we have to make sure that we are delivering adequate oxygen for the tissues to extract, and that we can help identify this excess in the complete extraction by looking at the mixed venous oxygen saturation. Tissue hypoxia is independent of mechanism. What that means is that it doesn't matter whether the tissues are hypoxic because the hemoglobin is low, or because the delivery is low, the cardiac output is low, or if the saturation is low. Any one of those three mechanisms can contribute to tissue hypoxia. But what this graph also suggests, and the data that went into it, is that if we are deficient in one, for example, hypoxemia or ischemia, we can make up for it by increasing something else, such as hemoglobin. Now, we teach in ECMO that it's okay to tolerate some hypoxemia as long as we have adequate oxygen delivery. But I do want to put out a word of caution that I don't think we have all the answers about the effect of moderate hypoxemia or even short periods of severe hypoxemia on organ function. While we know the brain can tolerate hypoxia and hypoxemia in the absence of ischemia, studies have shown that and have identified cognitive dysfunction and MRI-based brain structural changes in high-altitude climbers. And in one study of ARDS survivors who were hypoxemic during their ICU stay, even though they left the hospital functional and apparently normal, had very subtle neuropsychiatric changes. So while we often accept hypoxemia during VV ECMO, it's not something that we should accept if we can avoid it, and we should accept it only if we have no choice. So what I want to go through now are the determinants of oxygen saturation. And then based on this bit of physiology I'm going to present, you can see what goes into hypoxemia on ECMO and what we can do in order to address it. Recirculation is one of the components of oxygen saturation determinant. Recirculation is a phenomenon in which blood that we are reinfusing back into the circulation is then drained by the venous drainage cannula instead of going to the patient. So this is fully saturated blood that now gets drained. What effect does that have? Well, that reduces the effective blood flow. The recirculation fraction is the amount of flow that's being recirculated divided by the total amount of the circuit. So if I'm flowing 5 liters a minute on my circuit and I have 20% recirculation, that means I'm recirculating 1 liter. That means my effective flow, the flow that's actually carrying oxygen to the patient, is only 4 liters. And we have to consider this, the presence of recirculation, when we're looking at our circuit flow, because not everything we're pushing through that cannula is contributing to oxygen delivery to the patient. So it reduces effective flow. It also increases the oxygen level, the saturation that's going into the oxygenator, which reduces the amount of hemoglobin available for further oxygen uptake to take place. So it reduces the efficiency of our membrane lung as well as reducing the efficiency of our flow. We can calculate using a mass balance equation how much recirculation is going on. These are the very simple formulas. This one based on saturation. Does anyone see a problem on applying this very simple formula to calculating recirculation? It's this value right here, the mixed venous. How do we get mixed venous in a patient on VV ECMO since we're reinfusing oxygenated blood back into the circulation where we're drawing it out of? So we're not really able to measure circulation using these techniques without applying some tricks that may actually be a little dangerous. We can measure recirculation using techniques that were developed for measuring recirculation during hemodialysis. But I would submit, while useful in the research lab, I don't know of many, if any, ECMO centers that apply this at the bedside. But it is available, and it may be helpful in certain circumstances. So how do we deal with recirculation? We just recognize that it's a potential, and we try to minimize its existence. by optimizing our existing cannulation techniques, and I'll talk a little bit more about that, or looking at alternative cannulation approaches. The traditional approach to VV ECMO has been 2 single-lumen cannulas placed in the internal jugular and the inferior vena cava, but other approaches are available. You're by now all familiar with the bicaval dual-lumen cannula. We have 2 on the market now. This is a low recirculation circuit. The recirculation in this type of cannula has been measured at less than 3%. That's because it separates the drainage in the inferior vena cava here and the superior vena cava, allowing the blood that's reinfused to be directed more primarily at the tricuspid valve. This is the Protect Duo cannula, which is inserted across the valve. It drains from the right atrium and infuses into the pulmonary artery. It's low recirculation because the valve, the pulmonary valve, helps prevent blood from going back and mixing and causing recirculation. And there are other configurations described in the literature, such as aiming a cannula to the deeper in towards the tricuspid valve, the reinfusion cannula, or inserting it across the tricuspid valve. But by and large, we have not adopted these configurations very widely. But the most popular were low recirculation circuit. You've heard a lot of advantages to the dual lumen cannula. It's one-site cannulation. You can ambulate more easily and so forth. I would submit that equally important, if not more to me, is that the recirculation is low. I get more effective oxygenation for the same amount of blood flow. And I can now look at my venous drainage blood and get an idea what my mixed venous saturation is. So it gives me another physiological variable to monitor during support. One thing I forgot to point out here is that recirculation changes with blood flow. As you increase blood flow, you would expect your effective blood flow to increase the same as your pump flow, but it doesn't. It tends to decrease and taper off because at higher flows with the 2 single lumen cannulas, your fraction of recirculation actually increases, and it has more and more impact on your effective flow as you go to higher blood flows. So how do we manage it? You may consider, if you're running high pump RPMs and high flows, you may want to consider maybe I'm too high. That's not often the problem, but sometimes it can be. Then you may resort to checking your cannulas to make sure they haven't been malpositioned, converting to other configurations, but converting to other configurations while you're on ECMO is really a difficult scenario. So identifying any problems with your existing cannulation and how you apply flow is probably the most important 2 mechanisms. I want to talk a little bit about the membrane lung. We often just forget about it. It's part of the circuit. We don't worry about it. When we look at blood flow and we calculate oxygen delivery, we think about the patient side. But let's not forget that the membrane lung needs to be addressed as well. And you have to have adequate membrane lung oxygen transfer to meet the metabolic needs of the patient. If your patient requires 250 mils per minute of oxygen as their oxygen consumption, if you don't deliver that, they're going to be hypoxic no matter how much you flow. You just cannot meet the metabolic needs of the patient. So what can you do? Well, you have to depend on native lung function. If you've got an X-ray like I showed you, that's not possible. And you really don't want to depend on native lung function to add additional oxygen because then that destroys the whole purpose of putting them on ECMO by providing extreme lung protection. And if you fail to meet those needs, you end up with tissue hypoxia. So these are the determinants of membrane lung oxygen transfer. The blood flow plays an important part, and I'll talk about how that plays a part. But the more rapidly you send blood through the membrane lung within limits, the more gas you're going to transfer. Hemoglobin concentration. This is what's carrying the oxygen. If you have more hemoglobin, you can load more oxygen through the membrane lung and get it out to the patient. Inlet blood saturation. If you have a low inlet saturation, you can load more oxygen and get it out to the patient. If you have a high saturation, the converse is true. Okay? What gives us high oxygen saturations going into the membrane lung? I just said it, recirculation. And so recirculation can significantly impact your ability to get oxygen transfer. And then the SO2, or the inlet oxygen concentration in the sweep gas. This is the concept of rated flow. If you look at the membrane lung, you will see on the box that there is a rated flow. If you look at the quadrox, it's 7 liters per minute. Does that mean you can't exceed 7 liters per minute? No, you certainly can. And it may actually be helpful to exceed 7 liters per minute in certain circumstances. But it may also impair your ability to get oxygen across. So what is rated flow? I put here graphically what that concept is. If you look at this top part of the graph, you'll see here the inlet saturation, or the saturation 75% going in. As blood moves through the membrane lung, it picks up oxygen and its saturation rises ideally to 100%, and it comes out at 100% because we have gas transfer across. Okay? If we are operating less than our rated flow, that blood will be fully saturated. If we increase blood flow and are operating at our rated flow, that blood will just barely be saturated coming out. But if we push that flow even higher, then we will not be completely saturated. We'll max out how much oxygen transfer we can get, and the blood coming out will be hypoxemic. So not all outlet saturations that are low equals membrane lung dysfunction. It can be other causes as well. So I'd like to put this in. This is the curve provided by the manufacturer of the quadrox. And I'm mentioning quadrox commercially, but that's not meant to promote it at all. This is a graph of blood flow up to 7 liters per minute and oxygen transfer. You can see a little over 400 per minute. Is this what you're going to get in your patient? Not necessarily. These are very standard conditions. Hemoglobin of 12, inlet saturation of 75%, 100% sweep gas, and a sweep to blood flow ratio of 1:1. If you go outside these parameters, this curve is going to look quite different. And if I were to push the blood flow even higher under these conditions, you would see that this would plateau off. This is the concept of rated flow. It's the flow above which you achieve no increase in oxygen transfer. Well, let's look at the effect of anemia. Remember, manufacturers published this with a hemoglobin of 12. Let's say your patient has a hemoglobin of 8 instead of 12. This is what your curve is going to look like. You're not going to be able to bring on as much oxygen, and your rated flow is going to drop because you won't be able to add, you'll be able to come out of the oxygenator at lower flow, fully saturated, and above that, you will not have any increase. But the DO2, the transfer here at 5 liters per minute is 340, looking at this point. If you let your patient go down to 8 at 5 liters per minute, that's not even 250 cc's per minute. You're probably not even meeting the needs of your patient, and there's no way you can adequately oxygenate this patient. And that's at an effective flow at 5 liters per minute. If you've got 20% or 30% recirculation, you're operating way down here. Let's look at inlet saturation. At 75%, this is the same curve applies, but if your inlet saturation rises, then you're going to drop down and your rated flow is going to drop as well. There's just not as much oxygen available to bring on, hemoglobin available to bring on additional oxygen. And similarly for the sweep gas, oxygen PO2 or fractional oxygen, fraction of oxygen in the inlet of the sweep gas, as you decrease that, at higher flows it has an impact, but at lower flows it has no impact. Okay? Patients are often weaned from VV ECMO by reducing the oxygen inlet concentration, and that is effective here, but only at higher flows. It's not effective at lower flows. So let's now move on. Now that we've talked about the membrane lung itself, let's look at how much flow we're providing to our patient. And this is effective flow. Oxygen saturation is a function of the extracorporeal flow fraction. What does that mean? I mean, how much of the cardiac output am I capturing? Okay? If I'm capturing 50% of the cardiac output, if I'm flowing 5 liters per minute and the patient's cardiac output is 10, I'm capturing 50%. So 50% then of the oxygenator blood is going to be mixed in with the remaining 50% of the mixed venous blood. If this is, say, 60%, then you're not going to be able to get anywhere close to 100% sat. As you shift your extracorporeal flow fraction to the circuit, if your cardiac output gets lower or your flow gets higher, you'll increase your oxygen saturation in the blood. Okay, very straightforward. And here's another concept. Oxygen delivery from the circuit to the patient is independent of the patient's cardiac output. Now, I just told you that as the cardiac output goes up, the saturation is going to drop, right? However, because of the higher flow, they're maintaining the same oxygen delivery. So even though the saturation goes down, they extract less in the periphery, and they're still able to deliver. So your extracorporeal flow fraction is one of the primary determinants of oxygen saturation on ECMO, during VV ECMO, not VA. Mixed venous oxygen saturation is an important parameter to measure on ECMO if we can get it. The only way you can get it and use it effectively on VV ECMO is if you have a low recirculation circuit. Otherwise, recirculation increases that value above the mixed venous, and you're not able to figure out what the patient's mixed venous is. So how do we approach hypoxemia? I'm going to spend a couple of more slides. This was published a few years ago in intensive care medicine, and I think is a fairly good paradigm to get started. If you have a patient whose saturation is low on ECMO, look to see, make sure your equipment is functioning, your cannulas are not positioned such that circulation has increased. And if so, you want to focus on your cannula and your system. If you have membrane lung dysfunction, then obviously changing that is going to be important. The next step is increase your blood flow. Increasing blood flow will increase oxygen delivery to the patient from your circuit. However, you can't increase this to very high levels. If you're, for example, flowing with a dual lumen bicaval cannula, you won't get to 6 or 7 liters per minute. You might get to 4.5 or 5 liters a minute at most. And even that's a little bit risky with respect to hemolysis. But if you are running a lower flow than you could be safely and can increase it safely, then by all means do so. Otherwise, look at the hemoglobin. If the patient's anemic, then for all the reasons I just told you, you're not getting adequate O2 transfer in your circuit. So go ahead and transfuse the patient. Following transfusion to an adequate hemoglobin level, and I'm not talking about giving 1 unit, if your hemoglobin's 8, giving 1 unit of blood. I'm talking about getting that patient's hemoglobin up to 12, 13 or so to be able to really see the effect. If then they're have an adequate hemoglobin and an adequate flow and they're still hypoxemic, that's probably because their cardiac output is high. Now they're hypoxemic, but they're not necessarily hypoxic. They're getting plenty of O2 delivery. So the SAT might be 80%, but their lactate levels are normal. If you measured the SvO2, it would be above 50%, but they're still hypoxemic. Now, we've taught in also training courses, well, if they're hypoxemic but they don't show hypoxia, just tolerate it. And that worked fine for us for a long time, and patients did well. But what's happening now? What's different? What's different is our patients are now awake. We're waking them up, we're reducing or eliminating sedation and having them interactive, and they don't like to be hypoxemic. What is the body's natural response to hypoxemia? Increase your cardiac output. So this is a vicious cycle. As the patient gets hypoxemic, they raise their cardiac output, which makes them more hypoxemic. So that then you may end up with a situation where, do I need to control the patient's cardiac output? So if you're comfortable that you have enough oxygen delivery to meet the needs of the patient through your circuit, and then you can consider reducing the patient's cardiac output. And we have used that effectively, and it has made patients more comfortable. There are two approaches. One is hypothermia. I'll put this slide in just to describe. If you can achieve 60% of the cardiac output, you can probably get a pretty good saturation, just to give you an idea. And I'm going to let Dr. Bartlett talk about this. But I want to talk about the effects of blood transfusion. That you can get a significant increase in mean drainage saturation and arterial saturation through transfusion. The use of hypothermia, I think, is useful in patients who have a high cardiac output associated with a high metabolic demand, because you can then decrease the cardiac output through decreasing heart rate and stroke volume, because you're reducing the patient's metabolic rate. And the body's response is, I don't need to have this high cardiac output if you've reduced my oxygen consumption. So you can effectively increase oxygen saturation in patients who are hypermetabolic, but otherwise are getting inadequate oxygen transfer through the circuit. Another approach is to use a beta blocker. We've used both approaches. We tend to use hypothermia in patients who have an excess oxygen consumption, and we tend to use beta blockers in patients who may have a normal oxygen consumption, but an inappropriately high cardiac output, such as from a hyperadrenergic state. And this can be effective in breaking that cycle of hypoxemia. So with that, I'd like to conclude. I think I'm a minute or two over, but in summary, hypoxemia is common in patients on VV ECMO. It may be tolerated well if the tissue oxygen delivery is maintained. However, we don't know the full implications of allowing permissive hypoxemia. And we can usually manage hypoxemia pretty effectively in almost all of our patients if we pay attention to the principles that I gave you in this lecture. With that, I'll stop. You want to do questions at the end? Okay.